Welcome to AETCM, the emergency medicine channel. Today we are discussing about coma and its differential diagnosis and how to make a diagnosis of causes of coma in emergency room. Coma is a deep sleep-like state from which the patient cannot be aroused. Persistent loss of consciousness or coma indicates disorder of arousal mechanism of brainstem and encephalon, and it indicates bilateral hemisphere or brainstem disease. Normally, our consciousness is maintained by ascending reticular activating system and its bilateral projection to thalamus and cerebral hemispheres. You can see the ascending reticular activating system here, that and its projection into the cerebral cortex. Other definitions like which can be close mimicker of coma are drowsiness, that is inability to sustain wakefulness in the absence of an external stimulus; obtundation, that is answers or response to painful stimulus, otherwise drowsy; stuporous, irresistible desire for sleep, and the patient can be aroused with vigorous stimuli. Vegetative state, it signifies an awake but unresponsive state. Locked-in state, in which an awake patient has no means of producing speech or movement in order to indicate that he is awake. So these are the differential diagnosis and its definitions which can mimic a coma. If you see the DDs, like their various clinical findings, you can look into this chart. I'm not going to explain all these things because it takes longer time. So these are the common differential diagnosis for coma. They are not the causes for coma. Differential diagnosis which can mimic coma. So they have got various features like awareness, sleep-wake cycle, response to stimuli, motor function, respiratory function. So these are the common differential diagnosis. That one important differential diagnosis is brain death, that we'll discuss afterwards. Now we can see the causes for coma, that is very important. The most common cause in emergency room is always hypoglycemia, but there are multiple causes. We can see metabolic, like drug overdose, drug toxicity, anesthesia drug induced coma. They're all iatrogenic. Diabetes can produce diabetic coma, hyperglycemic coma or hypoglycemic coma. Hyponatremia, but that is one of the common cause for altered behavior, but coma occurs in severe hyponatremia, hypothermia, hypothyroidism, like severe hypothyroid state, patient can have myxedema coma. Uremia, normally they present with encephalopathy, but high urea state in the body can produce uremic coma. Hepatic coma is very common. Chronic liver disease, hepatic coma is very common. Respiratory failure, that is hypoxic brain damage. Sometimes severe causes like prolonged cardiac arrest can produce hypoxic brain damage and permanent comatose state. Head injuries like cerebral contusions, extradural hematomas, subdural hematomas can produce coma. Cerebrovascular accidents like stroke, different types of strokes can produce coma. CNS infections like malaria, encephalitis, meningoencephalitis, brain abscess, sepsis, toxic encephalopathy. That means sepsis and the toxins produces altered behavior or coma. Other cause like epilepsy and post-epilepsy syndromes. Post-epilepsy patient can have prolonged coma sometimes, especially GTCS, general tonic-clonic seizure. Brain tumors, thiamine deficiency that produces beriberi, that can also produce coma. So these are the common causes. We cannot explain everything here because we are only presenting the major features of coma. Now, one of the important scales which can document coma is GCS. I have given a chart of GCS here. Total score of all these things, it is maximum is 15 and minimum is 3. So this is to assess the patient's coma state, and we can document the GCS score here, because whenever we examine a patient in coma, we always have to document what is the GCS score, and from that score we can know that whether the patient has improved or deteriorated after 1 hour or 2 hour. If we are again examining the patient and documenting this score, we can know that whether the patient has improved in GCS or he has deteriorated in GCS. For example, a patient who is having severe hypoglycemia, his GCS may be very low, like 3 or 4. But once we correct the hypoglycemia part, he improves very rapidly. So the score will become 15 after correction of the hypoglycemia. So documentation is very important. So we can document GCS. Another easy scoring method is AVPU score: alert, voice, pain, unresponsive score. So here also we can compare AVPU score with the GCS. Alert means patient is awake, it is equal to GCS 15. Voice responsive, patient responds to verbal commands, GCS is 12. Pain responsive, patient respond to painful stimulus, GCS is equal to 8. Unconsciousness is equal to GCS 3. Now this table gives different types of uh, like brain lesion, which can produce different types of physical signs. In that, most important things are pupillary size, oculocephalic reflex, that is eye movement, oculovestibular reflex, that is when we irrigate water into the ear, respiratory pattern, motor responses like decerebrate posturing or decorticate posturing. So all these things are very important when we examine a patient. These things are very easy, basic clinical examination steps. I will not be going into the details of these examination steps, but as a physician, when we are examining a patient who is having coma, we have to go through all these steps. We have to examine the pupil for its size, whether pupil size is smaller, larger, or anisocoria, that is both pupils are different in size. Then doll's eye movement, oculocephalic reflex, oculovestibular reflex, patterns of respiratory system like chain stalk breathing. All these things are very important. Hyperventilation, hypoventilation, all these things are very important. So first we'll discuss about pupil size. If pupils are asymmetrical anisocoria, that means there is some problem with the cranial nerves, or there is a problem in the brain. ICP, that is raised ICP, can occur due to bleed or any raised intracranial pressure. Now reaction to light, people constrict when light is shown to the either eye, so we can see the reactions, and sometimes patient may not respond to the light. So all these things are very important. You can see the pupil size here. Mydriasis means large pupil, meiosis means small pupil. In a patient who is having coma, there are a lot of differential diagnosis, like patient who is having meiosis, it can be due to intracranial hemorrhage, pontine hemorrhage, lateral medullary syndrome, that's a stroke. Patient who is having codeine overdose, fentanyl overdose, morphine overdose, other drug overdose can also present with meiosis. Whereas mydriasis, again, there is large people, dilated people, third cranial nerve disorders, autonomic seizures, brain death, cerebral edema, raised ICP, antipsychotic agents, atropine overdose. So many drugs also can produce this type of problem. So pupil examination is very important in a patient with coma, because from pupil examination itself we can know whether patient has got any of these disorders. So that is very important. Now you can see oculocephalic and caloric response. These are tests routinely done in emergency room. That's a normal pattern of dorsal you can see here. When the head is turning to left, you can see eyes are to right. When the head is turning to left side, the eyes are right side, the eyes are turning to right. This is a normal response in any patient. This will be absent in doll's eye movement. So that is very important. Here caloric response, this is done routinely in patients who is having suspected brain death. Now patterns of respiration, you can see there are different types of breathing patterns you can see in various conditions like Biot's respiration, Kussmaul's respiration, chain stalk respiration. All these things are very important. Patterns of this type of breathing are very important in various causes of coma. We will not be able to discuss everything in detail here because time is a factor. So different types of breathing are also very important in coma diagnosis. Now decerebrate and decorticate posturing. You can see the decerebrate and decorticate posturing here. Decorticate posturing is commonly seen in upper midbrain damage. Decerebrate posturing is seen in upper pontine damage. So when we are examining or when we are giving painful stimuli, patient responds like this. So that is decerebrate and decorticate posturing. When we manage a case of coma, we do a lot of investigation. The most important investigation in emergency room is blood sugars, because normally when the patient come with coma, we have to see whether the patient is in hypoglycemia or hyperglycemia. Next one will be always an ABG. We can know in an ABG, we can know whether patient is in acidosis or alkalosis. Most common comas are acidotic comas. So from that we can understand patient is having acidosis and acidotic coma. Then other investigations in emergency room are electrolytes. In that, most important electrolyte which can produce coma is hyponatremia. Hyponatremia should be ruled out first itself. Other electrolytes like magnesium, phosphorus, calcium, all these things, abnormalities in these electrolytes and minerals can produce altered behavior and coma. Potassium as such will not produce hypokalemia, as such will not produce coma. But patient who is having chronic liver disease with hypokalemia, hypokalemia can precipitate hepatic coma. Like that, patient who is having severe uremia, renal failure, they can have hyperkalemia and uremic coma. Potassium as such without any of these factors cannot produce coma in any patient. But whereas hyponatremia is one of the most important and commonest cause for electrolyte induced coma in emergency room. So from this chart you can know various presentations of various problems like DKA, lactic acidosis. Lactic acidosis is very common in sepsis and toxic encephalopathies. Toxic comas you can get lactic acidosis. Uremic acidosis you get in renal failure. Alcoholic ketoacidosis is one of the most common presentation of altered behavior and coma in our emergency rooms. Salicylate toxicity, methanol toxicity, hyperosmolar coma commonly seen in diabetic, hypoglycemic coma, especially patients who are on sulfonylureas or insulin therapy. So these are the common cause of coma and common investigation we should ask for in this line. Like we have to ask blood sugar, ABG, electrolytes, all these things. Now another important cause for coma is tonic-clonic seizures, generalized tonic-clonic seizures. Seizure by definition it's a paroxysmal event due to abnormal excessive hypersynchronous discharge from the aggregate of CNS neurons. The problem in seizures, especially in GTCS, after a GTCS, patient can have prolonged coma sometimes, and even after the recovery, patient will be having confusion. So seizure patient may not realize that patient had seizure, but he can have coma, and post recovery altered behavior also can be there in seizure. One of the important investigation we already discussed, that lactate. In emergency room, if there is a GTCS, there is a high chance that lactate can be elevated. So lactate will be a very good tool in emergency room to pick up GTCS because most of the GTCS lactate will be elevated. Many patients with GTCS can have hypoxemia, hypoglycemia. All these things also can help us to make a diagnosis. Hyponatremia also can present with seizures, so hyponatremia also should be ruled out. Now, coma and airway is very important. When the patient is in coma, he will not be able to protect his airway like a normal person. So generally, except in conditions like hypoglycemia and all, if GCS is less than 8, it is better to intubate the patient, because if we don't intubate a patient who is in coma, there is a high chance of aspiration. Airway protection may not be there in that type of patient. So we have to intubate the patients whose GCS is less than 8. But remember, a diabetic hypoglycemic patient can also have similar feature. Their GCS will be very low, but it's a transient phenomenon. Once we correct the hypoglycemia, immediately patient requires, that type of patient does not require any intubation. Now, blood sugars in coma, we already discussed. There are three important reasons for coma in diabetes. That is hypoglycemia, diabetic ketoacidosis, hyperglycemic hyperosmolar coma, and lactic acidosis, that is infection. So these are the important causes for coma in diabetes. But remember, the most common presentation of diabetes induced coma is hypoglycemic coma. Hyperglycemic state can present with coma if it is a severe hypoglycemic state. Otherwise, most of the patient will have altered behavior in emergency room. But theoretically, all these patients present with coma because they are classified under coma. So patient can have high blood sugar. Ketone bodies can be positive in diabetic coma, diabetic ketoacidosis. They can have acidosis also. Whereas in hyperglycemia coma, hyperglycemic hyperosmolar coma, they have high blood sugars. Ketone bodies are negative, and there will be severe dehydration. Comparing to, when we compare to diabetic ketoacidosis, hyperglycemic hyperosmolar coma have a severe degree of dehydration. Infection, most of these patients can have whether DK or HHS, they can have associated infection, or infection itself can present with coma in patients. Most of the time the lactate can be elevated because of activated metabolism, altered metabolic state in our body. So the lactic acid will be produced by anaerobic metabolism. Now, another important differential diagnosis for coma is that's an irreversible brain damage. We can call it as brain death. So that should be diagnosed without failure, because coma, we can treat the patient and we can bring back the patient to normal life. But in brain death, it is not possible. So we should know the definitions. The patient will be in deep coma. There must be no suspicion that coma is due to depressant drugs. That is very important. Hypothermia has been excluded, and that is because hypothermia patient will be in this type of prolonged coma. They have a prolonged coma state, but patient can recover back to normal life. There is no profound abnormality of serum electrolyte, acid-base balances, blood glucose concentration, and any other metabolic or endocrine causes. So this patient requires before branding the patient as brain death, we have to extensively investigate by 2 or more physicians, including neurologists. We have to do EEG, we have to do calorie test, we have to do apnea test. So many tests has to be done before telling the patient is in state of brain death. Now, there is a cocktail called as Coma Cocktail. It's not actually, strictly speaking, it's not scientific. But when we are not able to make a diagnosis, what exactly is the reason for coma, or when we are working in a primary care or secondary care settings, We can try these drugs, nothing wrong in trying, but rarely it can produce some complications. But we can try the patient with oxygen, dextrose, naloxone, and thiamine. Some patients may respond to this coma cocktail, but it is not scientifically recommended as a first line therapy in any coma. We should try to make what is a possible cause for coma, and we should utilize all the clinical tests to make a diagnosis of coma. So we have discussed about coma in emergency room. It will not be possible to cover the entire topic in 20 minutes because it's a very vast topic. We can only tell coma is a medical emergency. We should try to make a possible diagnosis for what is the reason for coma, and if possible treatment should be started as soon as possible. And if we are diagnosing brain death in a coma case, we have to be very careful. We have to use a set of investigation only to make diagnosis of brain death. More than 2 doctors are required. So we have discussed in detail about coma and its management in emergency room. Thank you.